We're going to talk today about update on PFO closure for cryptogenic stroke. I actually fleshed out the slides to discuss a few other topics as well. Cryptogenic stroke. Stroke is the fifth most common cause of death and debility in the United States. Large incidence, we see it in our population, this area in the state of Michigan, the Midwest, the Rust Belt, the Diabetes Belt. High incidence of stroke, number of consults, any neurologists, part-time neurologists, internal medicine doctors who admit patients to the hospital, TIA stroke, cardiology colleagues, Dr. Lee, Dr. Alani, numerous consults for stroke prevention, TEE, help us move these patients through the system. Stroke is common, it's a big burden to the healthcare system, it's a big burden. Of the patients that we see with stroke, 87% of the strokes that we see are ischemic in nature, the remainder hemorrhagic due to poorly controlled blood pressure, use of unregulated medications or medications that are not being dosed for their metabolism. And there's a high cost for stroke, not only for patients for hospitalization, loss of function, loss of family time, loss for productivity within the workplace and in their lifestyle. So this is an interesting patient that I had earlier in November of last year. A 38-year-old police officer who works out in Caro was with his wife in Grand Rapids having an anniversary. They're out in dinner, they're having a nice time. He suddenly develops difficulty speaking, a facial droop. He goes to the ER in Spectrum. By the time he gets there, symptoms resolve. They put him on aspirin. They did an echo, they did a bubble study with the echo, said you had a little bit of a PFO, but everything's fine, go home. I met this patient because he had another stroke, and he was transferred from Marlette over to McLaren, did a TEE, and he had a very large shunt. Did the workup, EKG looked good, monitored on telemetry, no atrial fibrillation, no other conventional risk factors, no other hypercoagulable state. But he's a younger guy, he's an active guy, he's a police officer. Normal carotid, normal lipid profile, no other risk factors. So this is his bubble study, and then it slows down here. So this is a bicaval view, and you can see the bubbles. This is agitated saline, and you see this whoosh crossing over this area here. This is the right atrium. This is a agitated saline bubble. This is the intraatrial septum, and you see this bolus of blood bubbles crossing through the atrial septum there. And this is a classic patent foramen ovale. That when you look at this, this is not only a PFO, but this is a PFO that has bidirectional shunting and has function as both a PFO and as an ASD. So what we did with this patient is the following. We put him on 30-day event monitor just because atrial fibrillation is a burden, and we didn't want to jump ahead of ourselves and close this PFO kind of just right out of the gate because we don't want to hit every single nail that we see with a hammer. We want to treat our patients with evidence and with science. That's what separates us from the charlatans that are out there. No AFib, follow-up did well, and we went ahead and closed the device. This is the example, this is the cartoon of how the device is placed. This is done through 2 venous punctures in the same artery we access with ultrasound, and place a 8 French sheath that harnesses the intracardiac echo that allows us to look at the device, and then we place a 12 French sheath for the device. We cross from the right atrium to the left atrium with a catheter and an Amplatz wire, and then deliver the device. This is a cartoon depicting the Gore cardioform device, which is the device that I uniformly use. Primarily because of ease of use, also because of safety data, although there are 2 devices that are currently on the market. As alluded to with the other speakers today, there is a plethora of device, and that the cardiovascular world is a union of both science and industry for the care of patients. This is what the device looks like. This here is the intracardiac echo directing up towards the intra-atrial septum. This device here, once it's released, sits with wings deployed on each side and creating a shield or a barrier and closing that flow back and forth. Now, cryptogenic stroke, defined as a brain infarction that occurs in the absence of large vessel atherosclerosis, absence of small artery intracerebral disease. We primarily see this in older patients, patients with diabetes, patients with other vasculopathies, embolization from cardiac sources, as Dr. Alani alluded to, stroke from atrial fibrillation. That's why detecting atrial fibrillation and making sure that it doesn't exist before closing a PFO is important, because you want to do best science for the patients and you want to treat the right cause. Also looking for normal serologies, coagulation panels, and make sure that you're treating the right thing, because placing a device in a patient has both pros and cons. And cryptogenic strokes from presentation, at least in the atrial fibrillation data, as I alluded to, we see a lot of consults for atrial fibrillation and stroke. It's commonly recognized that when patients come to the hospital and they've had a stroke with AFib, the most common rhythm that they're in is normal sinus rhythm, and it requires detective work and a brain-heart team approach in order to best take care of the patients. So the epidemiology of cryptogenic stroke and PFO, 25% of the people in this room have a PFO unless you're an amphibian, okay? They have 3-chambered hearts. And the question is what do you do? They're often seen on studies for other reasons. They're seen on TEEs for valve interrogation, for endocarditis. People get bubble studies. They get evaluated for migraine, and we'll talk about that later. The issue is the only clear FDA indicated reasons to close a PFO are for secondary prevention of stroke, or for large shunting, or for a condition called platypnea orthodeoxia, which is a diagnosis of exclusion, although it does exist in patients, and I've seen it and treated it. Now, in the past science, patients have been traditionally treated with a menagerie of different medicines: aspirin, Agranox, Plavix, Brilinta, warfarin, and the novel anticoagulants. And they've all been studied, and we'll touch on that when we look at the study data. Patients that have had a cryptogenic stroke have an increased risk of stroke up to 4 years of 5%. Oral anticoagulants for these patients have not conferred much of a benefit, and the neurology associations recommend dual antiplatelet therapy for cryptogenic stroke patients. Now, when we go from the science, the defect, and then where we've gone from the 90s to the 2000s, it's taken 20 years for PFO closure devices for stroke to gain FDA approval, and most of that was mired by poor study design, primitive technology, and, as often is seen in these complex procedures, learning curves. Not everyone has competent hands, and not all centers can best take care of the patients. So this is the dinosaur, okay? This is the primordial soup device that was used first. This is the Starflex device. And if you go across the sexy scale here in devices, you can see that there's obviously been an evolution, and devices have gotten less rigid, more flexible, and more deliverable. And there's less risk of perforation, device embolization, which is a bad thing to have happen for a patient, and also less device erosion, because you're putting a rigid structure in something that is moving, and you want that to be flexible. Compared to the devices, this device it stopped being used in 2000. Amplatzer and the Helix, which is now the Cardioform, are the 2 FDA devices. There is a registry note that there's a risk of device erosion with a atrial aorta fistula with Amplatzer. It occurs in under 1% of patients, but you don't want to be that one patient that has that happen. Both devices have a long-term risk within the first year of a 5 to 6% risk of paroxysmal atrial fibrillation, because you're manipulating a chamber that is electrically active. It does happen in patients. They get upset. You just have to let them know in advance through informed consent. Patients take a lot of time. We go through the procedure. We talk with them. Patients want it done right away, but you have to do the due diligence with the patients. As I had mentioned before, this has been somewhat of a passion and also a trial of perseverance. I started cardiology fellowship in 2002. The device that we had there was the CardioSeal and the Amplatzer, and these are still being used on human device exemption protocols. And the trials that were done during this window of time were mired by a number of bad things: poor study design and eager clinicians who wanted to close patients. So the collimator were open wide, the hole was wide, so a lot of patients were enrolled. But the patients who were enrolled in the early studies were not really the patients who would benefit the most. They tended to be older, diabetic, have strokes for other reasons. If you have patients that have lacunar infarcts from cerebral disease, doing a PFO closure is not going to reduce their risk of stroke from intracerebral disease. So those studies were all mired, and they also had a large number of patients who had TIA as opposed to stroke. That's why there's such a lag, because the data was not clean. The studies that were done later, the REDUCE and the FDA approval with RESPECT, we're now in this window. This arrow here in mid-2014 is when the PFO closure program at McLaren Bay developed. So that's a long period of time, and you have patients in this window that did not receive care. As I alluded to, the trial data, the trials were not very well organized and they were not very clean until you get to the contemporary era, primarily because they were not enrolling the higher risk patients. Lower risk patients, older patients, patients who had strokes for other reasons were not coming in. And what we see now are patients who have clear stroke, large shunts with large bubbles like we see there, or very floppy or hypermobile intraatrial septums. The term aneurysm is applying to the intraatrial septum, which I think that now that we've heard about aneurysms scares the hell out of patients. And that's another reason why I believe that they feel the impetus to get these things done, because they're told they have an aneurysm because it says so on the echo report. I spend 20 minutes talking with the patients that you don't have an aneurysm in your heart. Your heart's not going to explode. What you need is good care, communication, and coordination of how to take care of them. We're now in the contemporary era here, 2017. These devices are now good to go. It's the standard of care, and then the governing bodies of interventional cardiology, SCI, and the ACC have now recommended for patients who are considered high risk that don't have other clear causes for stroke, AFib, intracerebral disease, that this would be the standard of care because it reduces risk of secondary stroke compared to antiplatelets and blood thinner. This is a big, complex slide, but I just want you to look over here, high-risk populations versus low-risk populations. If you look here, the higher-risk populations, if you look at the intention to treat analysis, higher-risk patients, if you ignore the early studies because of bad enrollment, inclusion of patients with TIA, older patients, there's a clear benefit for treating patients. And higher risk patients as defined by MRI CT proven stroke, no other causes, largely abnormal TEE with large transitive bubbles. There's another scoring system that helps determine the risk of their stroke as associated with a PFO, and this is called the risk of paradoxical embolization score. I've seen a number of patients over the years and have closed a fair number of PFOs. Some patients present with stroke, some patients present with an acute limb because the clot, it's Russian roulette where the clot lands. And the goal is, being the detective and spending the time with the patient and working with your colleagues, which is why an assembly like this is worthwhile, because you're working on collaboration, and these patients are best treated by collaboration with the primary care doctors, neurologists, cardiology specialists, and your vascular surgery friends, because these patients are out there and they oftentimes may have had the embolectomy, they're put on aspirin and Plavix and they're sent home, and they may not be treated. So education of the community, review of causes. There should be a reason why you form a clot somewhere in your body and have a detriment. So approach to patients, as I had mentioned, multi-specialty care, all of the imaging studies, these are usually done within the first 24 to 48 hours. You have a stroke, you come to the hospital, you get a brain alert, stroke alert, you get an MRI, a carotid Doppler, 5 EKGs, you're on telemetry, you get a hospitalist, a cardiologist, a neurologist, you get your carotids done, you get a CTA if they're inconclusive, you get an MRA if it's inconclusive, you get a TEE, and that's where these patients are usually identified. What I do for patients that present with stroke with any other cause, my primary concern is still for atrial fibrillation regardless of age, because as Dr. Alani alluded to, it's an epidemic. Everyone has AFib. Okay, so there were two other topics that I wanted to discuss, and one is migraine, and migraine with aura, because patients often get referred for migraine. There's been 4 studies that have all showed no benefit, and it would be great if PFO closure was associated with reduction in migraine with aura, but it just hasn't panned out. The methodology of migraine with aura is that there's vasoactive chemicals that are in the venous bloodstream that are normally broken down through enzymes in the pulmonary circuit. These are your serotonins, your bradykinins, your other functions, and these collection of these vasoactive amines pop through that intraatrial septum and they go to the brain and they cause vasoconstriction and migraine in aura. There's also thoughts that migraine is associated with PFO because patients that have migraine with aura have an increased risk of cortical and cerebellar infarcts in the occipital and the cerebellum. But it just hasn't panned out in the trial, and some of that I think is just due to, we've looked at the trial before, you just have to include the right patients to get the right answer. And we all live in the world of evidence-based medicine. There are a lot of medical doctors who I think look at trial design and wait for trials to come back and hope for positive results, and we're crestfallen when things come out to be negative because we want to do what's best for the patients. The only other topic that's associated with PFO that I wanted to mention is a condition called platypnea orthodeoxia, which is a really funky kind of medical condition. These are patients who are short of breath. They're short of breath when they stand up. They have normal PFTs. They have normal CAT scans. They don't have orthopnea. They don't have PND. They're always short of breath. I had a case that I did at Hurley where there was a patient, physically active patient, very tall patient, who would be short of breath all the time when they were up, moving around. So we explored everything. The patient's referred to me for last resort. What's going on, doctor? So do the right heart cath, left heart cath, everything's normal. Do challenges, do speed up their heart rate to see if they have some kind of pulmonary hypertension. We do a TEE, and then we do a TEE with the patient sedated, sitting up. Huge shunt developed, closed it, patient's happy, no symptoms, physically active. So a lot of these boutique diagnoses, most of the time your patients are not crazy. Most of the time your patients are actually telling you that's something wrong, and the conventional wisdom is you've done the top 5 tests and they're both normal, so you send the patient to the psychiatrist or back to their primary care doctor for an escalating dose of Zoloft. But as a detective, and all of the people on the panel here have spent, hundreds of years in medical education and practice, except for Dr. Azid. He's under a decade. But, be the detective, try to figure out what's wrong with your patient. From a PFO closure standpoint, the trial design and the science has finally met up with what we've always known was going to work for patients. Okay. Thank you, everyone, for your attention.